Hit the subscribe button or visit us at auau.auanet.org.
Great. Thank you, Dr. Cookson, Dr. Jarrett. Good morning, everybody. I'm going to be talking about a fairly new concept in the field of urology, and that's genetic and genomic testing. And this is something which has sort of come on to urologists fairly quickly. And I think we need to embrace this and understand it because it's going to be incorporated into every aspect of our care, from screening to treatment decisions to management of a localized and advanced disease in the future. Thank you. Why is this all happening? Why has it happened so quickly? Well, the Human Genome Project was actually finished in 2003. Now, in actuality, it wasn't really finished. They got about 96% of the human genome mapped. But this was a massive project that took almost 13 years to take place. As the years went on, things happened more quickly. More rapid technologies allowed the sequencing of the human genome. Again, 3.2 billion base pairs was a massive undertaking. 10 years later, two very important things happened in the world, one in the public arena and one in the basic science, really legal arena. First one was Angelina Jolie brought to the world the concept that a BRCA2 mutated gene could increase your risk of inherited breast and ovarian cancer. The same thing happened that year that the United States Supreme Court decreed that the human genome, be it normal or mutated, could not be patented. Why is that important? Well, before 2013, something known as BRCA1 and BRCA2 were basically trademarks of one company that sort of had the lock on the BRCA1 or BRCA2 world. After that, the Supreme Court, it opened up almost the Wild West, and everybody that was interested in doing some type of genetic and genomic testing was able to get involved with inherited cancer genes. Now, I mentioned earlier that while we say the Human Genome Project was actually finished way back in 2013, there was actually about 10 or 12 more years of work that needed to get that last little bit of the human genome sequenced, and that actually occurred in 2022. However, we are still far away from understanding the human genome. Most of what we know about actually is sort of in the dark genome, things that we don't really understand, that don't appear to code for any protein, and not exactly sure why they're there. And this sort of iceberg indicates that we'll be studying this genome more and more basic science over the next few years to really determine, are there other aspects of the genome that we need to understand? So why is this happening? This came in like a whirlwind. If you look at NCCN guidelines before 2016, genetic testing was not even mentioned anywhere in the NCCN guidelines. In 2016 was the first mention of hereditary breast and ovarian cancer as a family risk for developing prostate cancer. So you had to look at the breast cancer guidelines before 2016 to even understand anything about inherited risk of prostate cancer in families. Well, in 2017, it got baked into talking specifically about familial hereditary genetic considerations. By 2018 was the first mention that germline testing be done based on risk, based on advanced prostate cancer, based on metastatic prostate cancer, and by 2020, it was then recommended. And a lot of what we're going to be talking about today with our colleagues here really relies on the fact that germline and somatic testing has now become a key element in the treatment of advanced prostate cancer. So we sort of jumped on the bandwagon in Philadelphia in the Kimmel Cancer Center. We had two large international consensus meetings held in Philadelphia in 2017 and 2019 where we gathered experts from all around the world to talk about what do we do about genetic testing of prostate cancer. And many of our colleagues on the program today were participants in that program. But this sort of set the stage for a lot of things that we're doing now in urology in using genetic and genomic testing for prostate cancer. So these are the four areas I want to cover in the next couple of minutes. There are basic concepts, inherited risk, practical considerations, and lastly, the evolving role of genetic testing in prostate cancer. So genetic testing in the world is really something that most of us have been familiar with from medical school and actually college and high school, but we have to have sort of a reboot of how we think about this. Genetics is very traditional, looks at single inherited genes. Modern genetics really looks at multiple genes and the interaction of different genes. The word genome actually refers to the entire set of genes in an organism. And the term we use today is really genomics and genomic testing, because it's the interaction between multiple genes, the environment, hereditary, that actually give us a guidance to understand the risk of both early and late prostate cancer. So if it was not for computers, there is no way that we would be able to understand the current state of affairs of genomic and genetic testing. So here's an example of the BRCA gene. This is just one portion of exon 11. The BRCA2 gene is 12 pages long of machine languages, ATGC, et cetera, et cetera. You might imagine it's humanly impossible. You know, when most of us are in college, you can do the fruit flies and look at whether they have different color eyes or different shaped wings and things like that. Today, we're so far beyond the ability to do this without computational biology. It's become very, very important. Now, you have to recognize that there are normally occurring genes and mutated genes. So when you see an M in front of our BRCA1 or BRCA2 or other gene, they have to realize that there is not one mutation, and this is a big problem we actually have. There are 800 or 900 different reported BRCA2 mutations in what's known as the NCI gene bank. That is the repository of all genetic abnormalities, mutations. I mention that because we have a little problem out there with a company that is directly marketing genetic testing to patients, and unfortunately, they're only doing one or two genes. So when you have a patient that gets one of these commercial tests they can just order online, and they say, oh, I'm okay. It's really a great disservice, I think, to patients, and I'm not sure the FDA should have ever approved it because they just look at one or two genes, and in fact, there are 800 to 900 mutations that you can have in the BRCA2 gene that can increase your risk of diseases such as breast and prostate cancer. So this is sort of my spin on modern tumor evaluation, where we've gone through gross pathology, microscopic, nuclear abnormalities, chromosomal abnormalities. Now we're down to true molecular pathology, where we're actually able to look at individual cancer cells and determine what is the genetic alteration that is either increasing the risk or allowing us to target the therapy more specifically. Now, if you don't listen to any part of this talk, if you can remember this slide, we would have done a lot of good for our urology community. There are germline mutations and somatic mutations, and both of them are very important today in the management of prostate cancer. Germline is what you inherit from your parents, your grandparents, your great-grandparents. They are found in every cell in the body except for red blood cells. Somatic mutations are something that I like to call the Wild West of the tumor. You can have genetically inherited mutated genes in that tumor, but once that tumor starts to develop malignancy, you can have all sorts of different changes in that tumor. So that is known as somatic mutations. And both are very important from screening and treatment standpoint today. So these are sort of three buckets I like to look at when we talk about prostate cancer genetic and genomic testing. The first one I like to call genomic profiling. These are the proprietary tissue-based biopsies we've been using for many years. These are things, as you see, from the different commercial companies, including the Decipher assay. These are really used for treatment and management decisions. They are really not meant for genetic testing of patients for inherited risk or actually for active treatment. Now, some of the issues that Dr. Bajoran talked about for Decipher, for example, can direct you towards radiation, non-radiation, adjuvant versus salvage, but these are really not used for advanced metastatic prostate cancer. Genomic tumor sequencing, that's the somatic testing. That has become very critical in the development of our new agents. We'll be talking a lot today about PARP inhibitors. PARP inhibitors are basically based primarily on the research done on genomic tumor sequencing. And again, they determine the eligibility usually for clinical trials, also the ability to prescribe direct targeted therapies. But remember, you can also see inherited genetic abnormalities in a tumor. The last one is a little bit more controversial, a little bit difficult to get our arms around, and that's looking at inherited risk. The genetic testing looks at inherited risk usually by a buccal mucosal swab or by blood testing. And again, there's a lot of commercial companies out there since 2013 when the Supreme Court made their determination. And basically, this is becoming more and more important for cancer screening and prevention. Also looking for what's known as cascade testing, looking at increased cancer risk in immediate relatives. And again, also used, as we'll talk about, for clinical trials. Lastly, just to mention deep sequencing, known as next generation sequencing. We talked about computational biology. 15 years ago, if you wanted to do a BRCA1 or BRCA2 gene, that's what you ordered. Today, most of these are done on a gene chip, and it's usually just as cost effective to order one gene as opposed to a whole panel of genes. And you gotta be very careful. This is very expensive technology, although the cost has come down dramatically. Recreational testing, the things that you can order online from all sorts of entities out there that promote themselves to general patient populations, they're unlikely to do deep sequencing. What does deep sequencing really mean? Think about all those tens of thousands of ATGC sequences. Deep sequencing means you go into an area and you sequence it over and over and over again to make sure you're not picking up a read error. Because you might imagine with 10,000 or 12,000 base pairs on the BRCA2 gene, just one look at that, you might miss a ATGC mismatch. So deep sequencing goes back and looks at the same area over and over again to minimize the chance that you're going to get a miss. Lastly, I just want to mention polygenetic risk score, because this is something that's coming down the line very rapidly. Right now, this is not really part of genetic or genomic testing. However, this looks at what's known as SNPs. And SNPs are variations in the DNA that occur in all of us. They account for things like blue eyes and green eyes and brown eyes, hair color, skin color, and the like. These are normal variations that occur. They don't really, at this point, imply any type of very specific inherited characteristics, but again, they are being looked at as being reported as associations between increased risk of prostate cancer. Again, more to be seen about SNPs, but again, you just need to understand the polygenetic risk scores are coming very, very rapidly. Next, I want to just talk a little bit about prostate cancer and inherited risk characteristics. We all know that the majority of prostate cancer patients today have no family history. It is sporadic. And again, that's about 70% of our cases. Other patients, you kind of get the idea that something's going on. Grandma and the mother died of breast cancer, but no one in the family had prostate cancer. You sort of get the idea that something is going on in the inheritance of these genetic abnormalities, but you can't have anything very specifically identified. The ones where can really make a significant difference are in about 15 to 20% of patients who have true inherited prostate cancer. These are the ones where you can do genetic testing and actually show that in their family, there is a mutated gene that's passed down from generation to generation. So that's not to say genetic and genomic testing is not important for sporadic cancers, because as patients progress and develop metastatic disease and refractory disease, absolutely it's important. But when we're talking now very specifically about inherited risk for cancer, we usually can only identify that in 10 to 15% of patients. It's very important today that as urologists, we take a bigger picture of inherited cancer risk in patients, and we'll talk about that in a moment. So in the 10 to 15% of patients that we identify the cancer is inherited, most of the time it's a BRCA2 mutation in prostate cancer. BRCA1 is more prominent in breast cancer. But we have to remind ourselves, these do not cause cancer. They are not the cause of cancer. However, if you've got a mutated gene, the chance that a patient is going to have a more aggressive, more likely to have metastatic disease goes up dramatically because of issues with repairing the DNA, and we'll talk about that in a moment. So genetic germline testing has an impact on potential treatment options that we talked about, but much more importantly, today, we're developing more and more interest in screening family members who might have increased risk of developing cancer. So here is just a very short list of prostate cancer genes that have been associated with the disease. I want you to note that most of them are what's known as the DNA repair pathway. So when your DNA duplicates, it doesn't do it properly, and you end up with a malignant state. Now, again, it's not causing the cancer, it's not causing that malignant cell to develop, but once that malignancy develops, it does not allow the cell to correct the alteration because these correction genes are mutated in the DNA repair pathway, and again, you can go on to develop more advanced disease. I've highlighted there the HOXB13 gene. Many of you know that we've heard about the inherited prostate cancer gene where you have multiple members of a family under the age of 50 to 55 who develop aggressive prostate cancer. It's the androgen receptor or an androgen repressor gene that's associated with those patients. So the inherited prostate cancer that we've heard about over 10 or 15 years is due to the HOXB13 gene. Germline mutations in metastatic advanced prostate cancer. This is a very important paper that came out in 2016. However, at the end of the day, we now know there's probably about 20 to 25% of men with metastatic castrate-resistant prostate cancer have a mutation in one of these genes. And again, the tail of this is very long. There's many more genes. The common ones that you see are BRCA2, BRCA1, CHEK2, and ATM. So why are these genes important, these DNA repair pathway genes that we've talked about? Well, DNA damage elicits these genes to go ahead and make sure that the duplicated DNA is fixed. If these genes are mutated, they can't fix the abnormality in the DNA repair and duplication process. And what happens is you increase the risk of developing aggressive prostate cancer, metastatic prostate cancer, likely to be high Gleason score, but more importantly, men who have these abnormalities are increased at risk for developing male breast cancer, male pancreatic cancer, not only in them, but other members of the family, including ladies related to them, have an increased risk of developing hereditary breast and ovarian cancer. So again, these BRCA1/2 mutations, when they're inherited through a family, are really problematic. Anybody who's a non-believer, this has been out there for a long time. This paper's about 6 years old now. If you look at the two curves, and again, the x-axis goes at about 20 to 25 years. If someone has an ATM or a BRCA1 or 2 mutated gene and they develop localized prostate cancer, you can see that their survival is significantly impacted. We mentioned earlier BRCA1, BRCA2, more important in ladies than in men. However, I want you to note with the orange bars, even in men with prostate cancer who have these mutated genes are at increased risk of pancreatic cancer as well as male breast cancer. So again, when you identify these, it's very important. Lastly, talk about some of the practical considerations here. As urologists, we used to ask, hey, anybody in your family have prostate cancer? And we'd stop there. We've got to go a lot further now because of what we understand about hereditary breast, ovarian, pancreatic cancer. Fortunately, our commercial colleagues have these very nice family genetic sheets that patients can fill in. We don't have a lot of time in office hours to do it, but these are very helpful. But again, we got to be thinking more broadly beyond prostate cancer today. So here's an example of somebody with a hereditary prostate cancer risk, someone who has a BRCA1 abnormality. Looking at this as a urologist, I really can't tell you who should be screened in the family, who has an increase of risk of other cancers, including, I didn't mention this before, but colorectal cancer, Lynch syndrome, things along those lines are very important. I'm showing you this because we really need help from genetic counselors. I don't think most of us have enough time or skill to really sit down with a patient. Once you identify one of these inherited risks, I know we don't all have access to genetic counselors, but if you have access to one, I think you should develop a relationship with them and utilize them, because they're the ones that really understand what goes on in this world. These are some common prostate cancer genetic testing panels. You can see a variety of these common genes. Companies have different sequences of genes, but I think you'll see in this next one that you'll see some common prostate cancer specific panels. Some are much more broad. Two companies here have much larger gene panels. I get a little bit personally nervous using these because it may expose something not necessarily in our world of prostate cancer, but again, they are out there. And again, I just advise caution on a urologist ordering these risk panels, because they may uncover some other genetic alterations that we're not particularly in favor of. If you're going to be doing genetic testing, you need to understand the difference between pathogenic and likely pathogenic genes. These are genes that may or may not, mutated genes that may or may not be important. They're sent into the gene bank, and the gene bank looks at these every 6 months to a year and says, oh, you know what, that genetic abnormality is not important, or they identify the important abnormalities. As more and more genetic testing is being done, these NCI gene panels are becoming really very focused and very useful. So somatic DNA testing. This is the other aspect. This is not the buccal mucosa. This is actually identifying a mutated tumor, a mutated gene in the tumor itself. Today, liquid biopsies are becoming very, very common, not so much in urology, but certainly in medical oncology. And again, they will direct us towards treatment such as PARP inhibitors, pembrolizumab, and the like. So here's just one company, CDX testing, looks at over 300 mutated genes. Now, not all of these may be inherited genes, however, they are important for therapeutic decisions. So again, somatic germline testing or somatic tumor testing is becoming very important for clinical trial identification as well as treatment of advanced disease. And there is good data to suggest the new technologies on liquid tumor biopsies fairly well correlate with solid tumor. So what the implications here is that you don't necessarily need to go in and biopsy a metastatic lesion anymore. You may be able to rely on a liquid biopsy to detect the genetic alteration. Lastly, I want to just talk about some of the emerging areas of genetic and genomic testing. We all know the buzzword precision medicine. I think we've arrived there in prostate cancer. I think all these things we've been talking about come down to identifying a very specific treatment for a patient with a specific genetic abnormality. This is something you'll see over and over again today, but I want to highlight the yellow because this is really what we're talking about. Genetic and genomic testing for looking at things such as PARP inhibitors, for looking at things such as pembrolizumab, very important. So we're really getting that box there, that blue box really talks about precision medicine. We'll be talking a little bit about the PSMA scanning and lutetium-177. Again, that's precision medicine. You identify a specific characteristic, and instead of just sort of treating every patient with a treatment without understanding what's their chance of responding, precision medicine allows us to refine our treatments and identify patients who are most likely to benefit from that. So we talk a lot about somatic mutation testing, again, to identify actionable mutations. We talked about the BRCA1, BRCA2. These patients are eligible for PARP inhibitors. This is how PARP inhibitors have come into being, and the approval for most of the PARP inhibitors that we'll be talking about, such as olaparib or rucaparib, are based on somatic testing, identifying the homologous recombination defective genes, such as the BRCA1, BRCA2, and so on. Also, mismatch repair genes. We're familiar with this in urology because of the Lynch syndrome, colorectal cancer associated with increased risk of upper tract urothelial carcinoma. Well, it turns out that it also portends for prostate cancer as well. And if you've got a mismatch repair gene, you're eligible for pembrolizumab. Pembrolizumab is not specific for prostate cancer, but is specific for solid tumors that have one of these mismatch repair genes. So again, genomic profiling is becoming critical. As Dr. Moses talked about with advanced prostate cancer multidisciplinary clinics, this is really front and center when it comes to the management of advanced prostate cancer today, particularly for metastatic castrate-resistant prostate cancer. So microsatellite instability, it's not a genetic abnormality, but it's a read that there's something wrong. It doesn't give you a genetic read, but it tells you that if you have microsatellite instability, it's likely that there is also a DNA repair pathway gene somewhere, because it's a marker associated with the proteins that are involved with repairing errors in the DNA. So it doesn't give you the gene, but it tells you that something's going on there. Why is this important? Pembrolizumab for advanced prostate cancer is based on a mismatch repair microsatellite instability genetic test, doesn't tell you the gene, but it just tells you something's going on, and this patient has a likelihood of responding to pembrolizumab. You can also look at these mismatch repair genes by immunohistochemistry. This is very commonly done for our very small upper tract urothelial carcinomas where you might not have enough tissue to do genetic or genomic testing, but you can certainly do staining looking for mismatch repair. So the AUA Astro guidelines basically have validated this. The 2021 also now includes talking about patients with metastatic hormone-sensitive prostate cancer. We'll be hearing a lot about these new guidelines, but essentially the new guidelines validate what we've been doing over the last few years in this area. So to wrap things up, why is germline and somatic testing important? Well, risk assessment. Certain types of cancers, aggressive cancers in family, which members of the family should be tested. Prevention, we're not there yet, but obviously identifying patients at risk for increasing their chances of having an aggressive metastatic cancer. We'll be working on different approaches to disease prevention in these patients. Certainly prognosis. We've identified the fact that if a man has prostate cancer and he's got a BRCA2 or BRCA1 abnormality, he has a chance of developing a more aggressive form of prostate cancer and maybe needs to be screened differently and followed in the future. And lastly, treatment selection. There's absolutely no question. Treatment can now be individualized more and more using genetic and genomic testing, particularly for patients with advanced prostate cancer. So if you're going to be doing genetic germline testing in patients, these are some of the guidelines that you should look at. Many patients with more than 2 relatives less than 55 years of age, close relatives, first-degree relatives with a lot of prostate cancer, patients who have more than 2 cases of breast cancer, pancreatic cancer in the family. Again, as urologists, we need to start thinking a little bit more broadly about this category of testing. At this point, active surveillance, it's not locked in yet, but we need to start thinking about if in the family there's a genetic abnormality. If a patient has one of these genetic abnormalities, there's some early data out there that suggest maybe they're not the best candidates for active surveillance. So basically, we have extremely rapidly developing recommendations for prostate cancer genetic testing in decision-making. Again, we've talked about the most common mutated genes we need to be familiar with today. Today, all patients with metastatic prostate cancer, either hormone sensitive or metastatic castrate resistant, should have germline testing as well as somatic testing. And again, I'm a big believer in working in a collaborative fashion with genetic counselors. I know we don't all have them available to us, but if you have one that's available, please consider using them. And again, many, many new advanced prostate cancer therapeutics that we're using today are associated with precision medicine and genetic and genomic testing. So again, thank everybody for your cooperation today. And again, I thank Dr. Cookson and Dr. Jarrett.